Let me start with Dr. Montgomery and pose a question myself. A terrific presentation that covered really a lot of essential details. But I was really intrigued by one of the things you said about lumpectomy versus mastectomy. And unless I misheard you, you said if you're in the Northeast United States, you're more likely to get lumpectomy as opposed to mastectomy, implying that, and I don't mean to be facetious, that breast cancer is a fundamentally different disease in the Northeast than it is in other parts of the country, or was there some other reason for that?
There are many other reasons than, no, it's not a different disease. It's just that there are regional differences with respect to access to screening, cultural differences with respect to people getting routine screening and how early detection versus presenting with locally advanced breast cancer. Also, patients who live in the South or in places that are much larger geographically have a much harder time going to radiotherapy, for instance. And so there have been studies that have shown that if you live far away from a place that can offer you radiotherapy, you're not offered necessarily, or it's prohibitive to have a lumpectomy and stay in a hotel for 5 weeks while you get your radiotherapy. So it's not that it's a different disease, it's just when you present with that disease based on screening and access to the different care modalities.
That's a terrific answer, and I'm gratified that there's at least a very rational and kind of pragmatic explanation for a subset. I was being deliberately provocative. Some of you may be familiar with something called the Dartmouth Atlas, suggesting that there are actually wide disparities geographically in a variety of kinds of both surgical procedures, diagnostic tests, other therapies, some of which probably don't have a rational basis. And this was one of the items that came to the fore during healthcare reform. But this point about the difference between a rural area, access to a therapy, which really does relate to geographic distance, that was a critical point. Questions from the audience?
Thanks. I hadn't actually heard of that being done before for patients with lumpectomy. And I had a two-part question. One is that something that is currently being used to treat patients on a routine basis, or is it a new thing that's still being developed? And also, it seems like the kind of decision that would have to be made with help from the medical oncologist as well to things like, you know, the receptor status of the tumor seems to be something that would probably determine whether or not you're a candidate for that type of radiation.
Mm-hmm. So partial breast started, I'd say at this point it's got to be about 8 or 9 years old with Mammography. And so it has been around for a long time, and societies have, you know, the American, you know, the Society of Radiation Oncologists, American Society of Breast Surgeons, ASCO, they have come out with consensus statements as to what type of patient it is appropriate, it is acceptable standard of care versus what type of patient it would not be. Right now, it is considered standard of care for a person with tumors less than 2 centimeters in size, estrogen receptor positive, over the age of 60, and node negative. So it's a very, you know, so which oddly it is a significant majority of the patients who present. And then there are also other types of, you know, issues about whether or not that is an appropriate with respect to the woman's breast size and close to skin, things like that. But so there are absolutely patients for whom this is accepted standard of care. And then there are people, whether it's people who are estrogen receptor negative, lobular histiotype, which tends to be a much more diffuse tumor, people with positive lymph nodes, where you think of, okay, at some point, cancer had to go from point A to point B, so should we radiate that point, that pathway? So these are all active areas of investigation, but it is certainly offered relatively routinely to a certain subset of patients and is offered here at this institution.
Other questions from the audience, if any? Yes, please.
I had a question regarding the minimally invasive core biopsy. Has there been any discussion about a cancer being removed or any one of these new agents being injected during that minimally invasive procedure? So you go in with the needle. You biopsy the tumor. Now, once you've discovered where it is there any way for the oncologist and you to get rid of it right there?
Well, that's a great question. And to my knowledge, at this point, there has been some work done in trying to use stereotactic placement of radiation seeds. But I think that what Dr. Montgomery was talking about really has really become the newest and the most utilized way of having a more local treatment. I'm not really familiar with any attempts to try to do that just at the time of the biopsy. Are any of the other panelists?
So in order to do that, one would have to have a pathologist there. Obviously, you have to confirm the diagnosis right then and there. So that is logistically an issue. And then the question, of course, is there certainly have been, whether it's radiofrequency ablation of tumors. There was the Abbey, remember the Abbey? That
Right.
thing, you know, where they would put a very large core and take out a significant amount of tissue, or even cryoablation, which is freezing these tumors. The problem occurs twofold. Number one, it destroys the tumor entirely, so there is no tissue, whether it's to check markers, whether it's for research purposes. There's no real tissue left behind. And most importantly, from my standpoint, most of us, particularly who do breast conservation therapy, are very concerned about the margin status of these tumors. And there's absolutely no way to assess whether or not there's been 100% kill of these tumors, whether you're applying radiofrequency ablation, cryoablation, or even physically cutting this out with some sort of larger bore needle. The margins are not analyzed, and we know that, you know, the wider the margin, the less chance of recurrence, and positive or close margins significantly increase a person's chance of recurrence. That has always been the significant hindrance to those sorts of treatments.
I have a question for Dr. David. Most of us are familiar with going for mammography. Must you be referred for the other forms of screening? And is insurance covering these things? Is it something you can ask about if you're concerned?
It's a really great question. And patients, and it's interesting, you know, speaking about legislation now, informing patients of what their rights or opportunities are in terms of surgical procedures, and also even in terms of imaging. For example, the state of Connecticut recently passed a law saying that patients who have dense mammograms are eligible to get ultrasound, and insurance will pay for it. That's one state in the union. But so the world is really changing, and it's really a problem, and that's why it's a good question. What is patients' access from one level of care to the next? And that's really a work in progress, and I think it's very important, though cancer care is tailored per patient, on the other end of the spectrum we have screening that needs to address everyone. So I think at the present time, their screening guidelines are general ones that apply to everyone and specifically tailored to patients with high risk. So along those guidelines, I think it's sort of best to stick with that. And so patients who are eligible for mammography, so one would be eligible for mammography, ultrasound, and MRI as they fall into those established criteria.
The question really, though, raises the larger issue, which we won't really have time to discuss, but is worth at least articulating and bringing to the surface. You did a terrific job of illuminating these newer modes of imaging, but it always begs the question, so the larger question, leave aside even access and even cost effectiveness. Why do you choose one over the other? For which patient? What are the risks of doing them? Gamma rays, you know, you could turn into the Incredible Hulk, right? No, seriously, you do have, it is a damaging form of radiation, and there's a level of concern, as opposed to MRI or ultrasound, which at least as far as we know, are different physical modalities without a radiation consequence. So this is actually a very difficult thing, and it epitomizes that mammography controversy, and it even hinges on a deeper question, which some of the, let's say, naysayers have said about mammography. And that is that many of these early, let's say, ductal carcinoma in situ that you find will never, ever in the life of that woman trouble her. Now, that may be very disturbing for people to hear or worry about. And we're not talking about something that's clearly a false positive. We're talking about something that absolutely will meet the criteria of some malignant cells. And yet, I think the honest answer, but please correct me if my assumption is wrong, is that we don't know enough about the natural history of those individuals. In the flip side, for men with prostate cancer, we know there are a lot of men who come to autopsy and they have little foci of prostate cancer and never will in a million years have killed them, right? So this is really what bedevils the entire subject, what makes this so difficult. That said, let me just balance it. Let me pause. So any comments or thoughts from any of the panelists? I mean, do we have the answers to these questions? Is that even a legitimate issue? Natural history and whether with screening, vigorous screening, we're picking up things that would never have caused the patient any harm.
Yeah, it's absolutely a legitimate issue, and that's what the whole focus on gene expression profiling is really designed to address, is to identify those tumors that really need to be treated. There's also a line of thought, there's at least one paper in the literature, it's very controversial, but it suggests that many breast cancers may spontaneously regress.
Yeah, again, not to carry this too far, folks familiar with the Women's Health Initiative? Women's Health Initiative was a transformational study which basically changed practice, and it did change practice in the United States, so that typical hormone replacement therapy, which was being given to a lot of postmenopausal women, stopped being given. There was a measurable decline after the report of the first papers in roughly 2002. And guess what happened? Within a very short space of time, the incidence of breast cancer in that population went down. And it was the incidence of breast cancer in women who were estrogen receptor positive, which speaks to Dr. Sperano's point. People scratching their head, how could that possibly be? How could, and there was evidence that these events were connected. So if you're following me, you suddenly decrease the number of women who are being exposed to estrogen postmenopausally, and it seemed as if within an unimaginable period of time. One speculation, it's a speculation, is some of those women had incipient cancers that were subclinical, would have emerged if they continued to be fed estrogen, and then with the withdrawal of estrogen, they weren't. So this is a complex issue, and again, there's a lot of emotion and passion. What we need is data from the kinds of studies that we've heard here. Other comments?
I think one of the problems is that you know, breast cancer is a very heterogeneous animal, and that you know, even within one tumor, you're looking at something that's 50% estrogen receptor positive, 20% estrogen receptor positive. We consider those people to be ER positive, and we treat them as such. However, there's, you know, the other 80% that are, in theory, estrogen receptor negative. So each, you know, to this overarching concept of breast cancer, it's very difficult to predict the natural history because every breast cancer can behave extremely differently. And, you know, you're right, the vast majority, there is a significant amount of DCIS that may not affect the person. And of course, autopsy studies have done the same thing in breast, that prostate has been shown, that there's lots of women with DCIS on autopsy studies. The point is, you're 55, you have DCIS diagnosed. Are you going to bet that that's going to regress, or are you going to think that that's going to continue and be invasive? And this is the stuff that Dr. Sperano and these prediction models, it's honing down onto these, within the realm of breast cancer, the subtypes and how these different cells are going to behave, and predicting what's going to behave well and what's not. But right now, it's more of a shotgun, which is, you've got DCIS. I can't assume it's going to take 10 years to become invasive. It could take 2 weeks.
You know, these are terrific points, and let me just close this part of the discussion by just saying that, you know, you in the current era already know that there's a small proportion, fortunately, of women who are at extraordinarily high risk, not just for breast cancer, but for bilateral breast cancer, and even potentially in association with ovarian cancer. These are women where we know about specific breast cancer genes. These are mutations that occur in their genome in every cell, but they manifest as breast cancer. And these individuals undoubtedly require much more careful, much earlier screening, much more aggressive treatment. Some of them choose to undergo prophylactic bilateral mastectomy. There are other potential ways of following them. And if I'm not mistaken, Dr. David, it's particularly this group where there's recent data that MRI in particular is warranted and probably reimbursable, et cetera.
Right. Well, you make a very good point. And in going back to the first slide that I showed, when we try to think of designing strategies to find breast cancer, you know, why? In other words, if we're looking for very early cancer, we don't, as imagers, I need help from other groups to say, well, which of those cancers are you looking for? Which ones are you going to treat? We can only design strategies for things that we're asked to look for. So when we try to look for cancers at the earlier stage, we can find them. That's a totally different question than what do you do about it once you do. But if you can answer that question, then maybe not everyone needs to be screened for that. And those are some of the issues when you talk about saying, well, maybe you don't need to start breast cancer screening until age 50. That's a big question for society. How early a cancer do you need to find? And to some extent, that's a little beyond the purview of a question of how can we design the best image. But that's a big factor. And in terms of how we screen for high-risk patients, that's really one of our most interesting areas, and one of the most interesting where these new recent advances make a big difference. So the one that's most in clinical use for sure is breast MRI. And patients who are high-risk patients, it is reimbursed, and frequently, along with clinicians, there's a plan for maybe every 6 months a patient may get an MRI and then alternate with mammography and ultrasound, so that we try to use all the modalities in complementary ways to help find tumors that need to be treated.
A couple of final questions.
If you took cost out of it and insurance out of it, what is the most reliable method of screening?
What's the most reliable method of screening? That's the million-dollar question. You know, I think at the present, it all depends what your goal is. Like, what's your goal of screening? If you say we want to find the tiniest breast cancer in everyone, that's a very different question. So I think taking even cost out of it, society needs to decide what are we looking for, and
if I may, it goes beyond that. I think underlying your question, it has a little bit of the tone of that debate I was referring to earlier, is that the only issues, that it's a question of rationing, that's a question of cost or insurance. It's not the case. I think people in general don't seem to comprehend the risk of unnecessary procedures, unnecessary radiation, et cetera. There are data about how many women need to be screened to save one life. And you can lose sight. You can focus on that one life and say, well, if you're that one person, that's all that counts. On the other hand, what about all the, quote, unnecessary biopsies, the complications, possible things that can go wrong? So it's not just a question of cost. That's what makes this so hard. And we come back, I think, to what several of the speakers, but particularly Dr. Sperano, pointed out. It sounds like Brave New World, but the day may come where, you know, everyone will have their genome sequenced. And then if they do get, first of all, having that sequenced will say not only who are the women who are at very high risk for sure of a potentially fatal breast cancer, bilateral, BRCA1 and 2, but even other more subtle kinds of changes. Those are women in whom for sure we'll want to have much more active surveillance because we'll know that there are consequences. So this is the issue, this kind of personalized, tailored thing, not giving unnecessary chemotherapy to 100 women just to save the 3, very important to save those, who are the ones who would actually benefit. One last question.
What's the criteria for clinical trial? All clinical trial. I mean, there's been advances where HER2-positive breast cancer now has Herceptin. Where would a patient, an early-stage breast cancer patient, fall into a clinical trial? How would that information be helpful moving forward with reoccurrence?
Right. So you really raise a very important question, is that how do patients find out about clinical trials? And usually it's through their healthcare provider. In delivering care at an NCI-designated cancer center, it's part of our mission to offer clinical trials. It's also now becoming part of community practice. It's more ingrained in the medical oncology community, mainly because, at least for more advanced stages of diseases, we really don't have satisfactory treatments for many diseases. So clinical trials offer additional opportunities. But it's particularly important for patients who have early stage and potentially curable diseases. And what trial is available to them depends upon the characteristics of the individual and also the characteristics of the tumor. But I can tell you at our institution, we have about 20 to 25 clinical trials, therapeutic clinical trials that are open at any one time for breast cancer.
I
trials for more advanced drugs had to be like metastases or advanced bone cancer?
No, most of the women that we enroll in clinical trials actually have early stage disease.
Okay, one truly final question here.
Dr. David, does it make it more difficult to check women with breast implants for cancer, and what would they use to? I'm sorry, this one.
Yeah, okay, so to repeat the question, is it, if I understand
More
it correctly,
difficult,
is it more
yes, with
difficult to image
the
patients who have breast implants to look for breast cancer? It's really interesting. You know, one might think intuitively that that would be true, but actually there's no real there's no evidence to suggest that.
So which one would they use? A typical mammography?
Well, it's interesting because women, you know, tend to maybe ask for MRI and want to skip mammography if they have implants, but one really can't do that. The information from mammography is complementary. So women who have breast implants should really go through the same type of screening as women who...
Should it begin when they get them, or at the age that you said they should start?
Well, I
as
think,
a baseline?
I don't think it needs to be factored into the decision, really. I think it would be based on other risk factors.
With that, we'll thank each of our speakers for really terrific presentations and also fielding questions. Thank you all for coming.